We were debating whether I should stay behind the podium, and you could just hear the talking voice, the disconnected voice. Well, it's a pleasure to be here. And I'm going to try to give you a little bit of an overview about mobility, provide you some challenges. Certainly one of them is accessibility of IOM. It'd probably be something to discuss. I have some hypotheses here that I'd like to share with you. One of them is that we talk about that assistive technology should be delivered in a team approach, but I'm going to argue that that actually rarely happens. That, in fact, I would argue that most assistive technology is one simply purchased by Walmart or at Walmart or Costco or Home Depot or whatever their equivalent is in Canada, which that's probably not a bad thing in some ways because it makes it more accessible, lower cost. And then a lot of the other assistive technology is simply provided by rehabilitation technology suppliers who are loosely regulated and not really, by and large, highly trained. And then I'm going to argue that new technologies are also slow to emerge because there's insufficient R&D funding for translational research in technology. There's SBIR funding, but that means you have to have you have to work with a small business, which prohibits working with Johnson & Johnson or Philips or any one of a number of large companies who may be able to bring some technologies to market that small businesses are not capable of bringing to market. And that doesn't, how do you get to the point of being able to have something that could be eligible for an SBIR? For you specifically, there's inadequate reimbursement for assistive technology. I'm lucky, I'm a veteran and I'm eligible for VA health care, and that allows me to get the type of chair that I have. This chair is not covered by most insurance. Now I'm lucky, I'm employed, and I could probably tweak that a little bit through using ADA accommodation or some other mechanism, but by and large, that's a challenge that a lot of people face. And then lastly, I think AT is this is like when I teach our residents and our PTs and our OTs. So the one thing you can pretty much guarantee that you will have a positive impact on quality of life and participation is assistive technology. A very simple demonstration is if I jumped into Henry Aaron's chair here, and you rolled my wheelchair away, that'd be pretty much where I would be until somebody brought it back to me. And you can do that with the other people in the room. You take the communication device away, and we're entirely I've become entirely dependent from a personally being an entirely independent person. Oops, maybe this isn't going to work. So I'm just going to make a little shameless plug for both my wife and our Center for Assistive Technology, and a little quote from Kareem Dale, who works in the White House. And that's that a team approach does work. My wife's the woman in the yellow jacket on the upper left side there. But because we are able to get complex technology by using OTs, PTs, engineers, rehab counselors, speech and language pathologists, and physicians working together. And I want to bring that up because I go to Resident, ISS, and a lot of conferences here and say, oh, you're never going to get a Permobile paid for, you're never going to get a K5 paid for, which is not true, actually, when you do work in a team approach. And we probably do $30,000 power wheelchairs a week in our clinic in Pittsburgh. And this is an argument I brought up because I'm going to talk about something like the iBot that cost $25,000. People would say that it wasn't reimbursement. It's really the fact that you have to do the right justification, the right assessment, the right fitting, the right training, all of the things that we heard about a little bit earlier today. Are you going to click the slides for me? Okay. So it was funny that Jeff mentioned low tech. We do some low tech, but I don't think low tech's the solution to everything. And there is high tech in the market and high tech coming to the market, which is going to be a challenge to your recommendations and to our So let's move on to the next slide a little bit. So exoskeletons are now out there. They're largely technology transferred from Department of Defense funded research now coming into rehabilitation. The Exo and the Rex Bionics and Rewalk in the United States are primarily used in clinical settings. The Rewalk is seeking approval from FDA to use it as a mobility device out in the community. The cost of these devices is in the $90,000 to $120,000 range, which is going to challenge our reimbursement system. I'm going to show you later some prosthetic limbs that are now in development or commercially available that cost within the same range, but they are being covered by insurance. These devices are not being covered by insurance. And there's a little bit of a bias. The Germans call it Edelbehindert. There's a differentiation between certain classes of disabilities and levels of reimbursement. And so this is a challenge we're going to see with people who are motor impaired. They are largely right now what they're simply doing is in some ways replacing the smart robotic treadmill systems or body-supported treadmill walking. In some ways, physical therapy, providing more skills. We can move on to the next slide. I'm going to transition a little bit about robotic wheelchairs, but to give you an idea, the World Health Organization came out with a report this summer saying that 70 million people need a wheelchair. Only about 20 million people in the world have access to a wheelchair. And only about 6 million wheelchairs are produced each year, of which we use 4 million of them in the United States. And the average wheelchair lasts 3 years. And 10 years ago, the average wheelchair lasts 5 years. So we're actually going decline. And I think that's not because technology, our technical capabilities have probably gotten better, but our reimbursement has gotten worse. And so because of pressure from reimbursement, manufacturers have built cheaper technologies. Next slide.
Rory, let me ask you a question here. Is it possible that that people who use wheelchairs are using them more because they have more functionality? They're actually getting more miles on the tires, if you will, and that's a reason why the chairs might be turning over quicker?
That's a great question, but no, that's not the case. Because there's been studies, there are a number of studies now. We're using basically data loggers to measure the amount of activity. And the amount of activity, actually I'll show you a slide later on, is about 2,500 meters per day for an average manual wheelchair user, and that's the same as it was about 10 years ago.
Rewind.
So there are robotic, you want to just go back and we can start. So there are robotic technologies that are coming out for wheelchair users as well. The idea of having robotic mobility as well as manipulation in order to perform greater activities of daily living independently. It's interesting that people are not looking to have fewer hours of caregiver assistance or less human contact. Most people would argue that they have inadequate number of hours of caregiver assistance as it is, and that having robotic technologies could augment that to provide a more complete day and greater autonomy over an entire day. So this is a project that we were working on. Interestingly enough, we were looking at a telehealth model originally where you'd have remote operation from a distance with a family member or a remote caregiver providing assistance to a person using robotic manipulators. And it turns out in our original experiments that people preferred to operate it independently. And so we've been working. This is an actual person with a disability, as you can see. She is an engineer, but she is using voice control and a PC tablet to control the wheelchair as well as both manipulators. What's fun is this is a Target store. So we had permission from the manager, but the customers and the staff don't know what's going on because that was part of a separate experiment to see the reaction of the public to having this type of technology in a public setting, which is pretty, as you can see, that it was pretty much innocuous, right? Then we've also we're looking at expanding mobility, one of the problems is that Medicare put pressure, so we basically fund Category 1 through 3 wheelchairs. Category 4, the highly active wheelchairs, are largely unfunded, although that's the category that the Veterans Administration and the Department of Defense most commonly provide. And there's pressure for expanding environments, like you were saying, Jack, to become more active, being a lot. Can I go out in a park? Can I go to a friend's home? Of course, I hope we're going to hear a little bit about visitability in the next presentation as far as changing environments and communities, but it's still happening rather slowly. And we live in Pittsburgh, and still most of the community is largely inaccessible. And this actually came out of a challenge. The Marine Corps wanted to take a group of the severely wounded veterans through Gettysburg and go over the trails and the rocks. And then, of course, that got picked up by other people. So our next slide. Margaret, I put this in there for you. You talked about coaching systems and having the coaches. So one of the problems with the chairs, like Stephen is using in the back, is that we provide these chairs to help prevent pressure ulcers or for alleviation of pain or venous thromboses or edema, and people don't use them as they're prescribed. And then the problems persist, and then the insurance company wonders why we spent $35,000 or $40,000 on a piece of equipment that isn't treating the problem. And we actually put monitoring systems on people's chairs and found out they weren't using the chairs as prescribed. And thought that the idea that might be able to help with this is to come up with a virtual coaching system. And you'll see that original part was how it could be tuned for different environments, so it's somewhat self-aware. And here it's addressing a safety issue. He's too far tilted back to safely go up the ramp. He gets a video signal from his therapist. The screen comes up that tells him what angle to tilt to be able to safely go up that ramp. He follows the directions and can continue on its pathway. And here we're going to see an example of he's been getting a reminder to perform a pressure relief. You need to perform at a certain angle and certain duration. That's one of the common problems. And in a certain form, so you need to tilt and then recline in order to prevent shear. And then the data is transmitted to the clinician, and we're letting the user select when they transmit it and what data they share, and then the clinician can discuss that with them. And this is helping his patient education. We found you actually don't need the system for many individuals long term. They need it to get to sort of internalize. We can switch. Internalize the information, and then they can go on from further. Transfers, maybe not directly related to mobility, is directly related to mobility, but not a certain mobility device, is also important to making the world accessible. So we did a study with the Access Board looking at independent transfers onto various surfaces of heights and distances, the gap between the chair. Because one of the things you don't often think about is if you when you transfer onto a chair, onto a toilet, or into a car, how far of a gap you have to jump as well, and what's the difference between seat heights. So we'll go to the next slide. And so this is the data from the study that so far, we're still continuing to collect data on this study. We hope to add another 150 or so people, and also do two-step transfers, like a tub transfer or some or into a boat or other things like that. Some car transfers or two-step transfers as well. But what it's interesting is the histogram there, that most people can only transfer within about 2 inches of the height of their seat of their wheelchair. So 2 inches down or 2 inches below. And it drops off pretty precipitously from there when you go higher or lower. And if you increase the gap, it drops off as well. And this group includes people that can do stand and pivot transfers, as well as power chairs and manual chairs. Next slide. We'll shift gears a little bit on prosthetics, or the next slide. So one of the fortunate things in medicine is we've got much better at helping. So I'm going to focus on primarily the younger population here, because there isn't, unfortunately, a lot of innovation going on for the older dysvascular amputee currently. I think that that will change as we learn more from the 1,800 amputees that have resulted from operations OIF and OEF, and the younger amputees. As you see, kind of like in racing, it's race car technology often gets into automotive technology later on. But there's a lot of challenging comorbid conditions. One of the things we can look at is using virtual reality, like Jeff was talking about, and how do you improve balance? How do the different prosthetics work? How does the footwear work? Affect that type of prosthetic technology. Next slide. And I think the real innovation is in power prostheses. Powered ankles are now on the market. There's a few limited powered knees on the market. This is Hugh Hare from MIT. Hugh's himself an amputee and developing prosthetic ankles. And then that's Greg Gatson, you might know him from the movie Battleship, using 2 powered knees to ambulate. Really, the powered knees are experimental at this point, but that's what the future will hold. Next slide. We should also talk about human mobility. Next slide. And sports and recreation. And we talk about the VA and DoD are the only enlightened agencies that cover sports and recreation equipment, which are also for health promotion and participation. My wife and I ride together. I have a hand cycle. She rides her bicycle. We're not unique. But things like quad rugby, wheelchair basketball also promote wheelchair skills and community integration and change of perception. Next slide. The same thing is for amputees and running prostheses. The military and VA provide running prostheses as well as daily use prostheses, whereas you don't get that same benefit in the private sector. Next slide. And there's clinical technology that's available and used, like our smart wheel that we developed when I was a graduate student, so many, many, many years ago, is now on the market, and about 100 clinics are using it to help understand wheelchair propulsion. If we go to the next slide, you can see that here's just a very simple example of an axle in the manufacturer's default setting, and the stroke frequency is higher. There's an impact spike at the original. There's a dip from slowing down the push rim. If you move the axle 2 inches forward, you decrease the stroke frequency, you get rid of the impact spike, you get rid of the slowing of the dip, and are all correlated with reducing the risk for carpal tunnel syndrome or rotator cuff injuries. Next slide. And you asked about activity. So I put it in the context. I didn't put it in the context over time, but unfortunately, data really hasn't changed. But about 2,500 meters of community-based activity is what people see. We've now got data on about 600 people. It's still pretty much about 2,500 people. About 0.8 meters per second, which is also kind of interesting because stoplights are set for 1 meter per second. So which means the average wheelchair user, manual wheelchair user, can't get across the street before the light changes, or can't get on the metro before the door closes. Then wheelchair basketball and rugby are about the same level of activity in about 30 minutes of movement in a 1-hour game. Next slide. And I wanted to throw in a little bit of low tech. We're working on a system to remove the one-arm drive, which we call the path lock. It just simply locks down. It helps overcome the road crown for long distances on sidewalks, but makes a simple one-arm drive. Or even here, if I'm trying to move with a hot cup of coffee in one hand, and I could hold it with one hand and push with the other. It's just a simple magnetic locking device. You can unlock and lock the caster to bias it. Next slide. And I had to mention for our hybrid systems, FES. I kid him once in a while that you don't see FES systems, but actually they are widely used to replace orthoses for things like foot drop. There have been FES walking systems. Unfortunately, because of some of the reimbursement problems, technology problems, they're not widely used. And then there are systems that use wheelchairs like Pawpaws that use power and manual propulsion together to come with a gap between manual chairs and power chairs. Next slide. I'm just about done. And I'm going to lead into our next speaker about some of our work, because you can't talk about mobility unless you talk about the environment, and transfers is a little bit about that. And we've been working, talk about big companies, with Clark Realty and the Michael Graves Group to come up with accessible housing for military facilities so that for soldiers and service members that continue on active duty. IDEA was part of this project as well. And all of this information, all the plans, all the research that went into this is available at the woundedwarriorhomeproject.org for free and accessible to all. Next slide. The homes, there's 2 homes that are real. They're at Fort Belvoir. 120 homes, new homes are planned. And if we can just, I need to turn to this. We have sound? Oh, no, probably only with your screen, actually. No, I have to plug it in. Oh, here it is. It's not long enough. Well, I'm going to just walk you, I just wanted to give you this little video of the home, walking it through. Fortunately, I'd say it ought to be a little bit nicer, but. And to point out, there are people living, there are 2 soldiers' families living in the homes now. But it's got some neat features. You don't need a key to enter. It uses their ID card, which has an RFID tag in it, and that opens the door. It also announces in the security system when somebody is there. If you're not authorized to open the door, you can still hold your RFID tag up, your military ID, and it will tell you who's there. It's got different floor surfaces to give visual guidance for people with TBI or low vision. Tub and shower in the bathroom, so it looks more like a standard bathroom. A technology closet to keep your wheelchair and prosthetics and all that stuff, and where you can charge them, and you don't have to have them all over the house. High-low sinks in the bathroom and in the kitchen. You can see how that goes up and down, and you can have the kickway for microwave at accessible height. It's got actually an indoor room for home therapy, or if you have a family member staying, you notice all sliding doors. There's an outdoor door into the therapy room. There's also an outdoor door in the master bedroom for fire egress. Temperature control for every room in the house, because if you have burns or spinal cord injury, you have temperature regulation problems. High particulate filtration system for people with allergies or sensitivities to smell. There's it's turning space in all the rooms. And it's designed to look like it's pretty much like a normal home. What they're doing is take an accessible design approach. Instead of what they used to do is 2 accessible homes per 100 homes built, is to now build all the homes like this and use them for everybody. Click this. So it's really about participation, and mobility helps promote participation. And it's my contact information.
Thank you. Thanks very much.